multinodularity. These are all the scenarios which you may be expected or you may be given in the exam. If actual case is kept, such cases may also, you should be prepared for everything. Today we are discussing a multinodular goiter in euthyroid state. You may in future may present a case of multinodular goiter with toxicity or a diffuse goiter in a euthyroid state like that. Any combination can occur. You should be prepared to discuss all cases. Okay, Goitre?
Yes, sir.
You start presenting, yes.
Yes, sir. I'm going to present the case of multinodular goiter. Demographic details. Name Mrs. Komadi, 50 years old female, was a housewife from Compet, belonging to low socio-economic class.
Yes.
Next. Came with the chief complaints of swelling in front of the neck for the past 4 years. Next.
One second. Has the nativity or residence of the patient got anything to do with the thyroid disease? Go back to the profile of the Yes,
sir. Compet, sir, endemic areas there may be.
This is Compet, all right. Generally, I am asking. Yes, endemic. What are the endemic areas for goiters?
Hilly areas, sir. Hilly areas.
Hill areas. Why, ma? Why is it so?
Sir, iodine deficiency. Iodine deficiency.
Yes. Okay. So that was the case some time ago, where the hilly people used to get their own salt, which was obtained elsewhere, not from the sea salt. So the sea salt is rich in iodine due to the presence of what? Where does the iodine in sea salt come from? What is present in sea which gives? That's a seaweeds. In sea you have got algae like seaweeds. Seaweeds are the richest source of iodine. Okay, so the weeds import the iodine into the sea water, which is getting mixed up with the salt present in it. So the source of iodine in sea salt is the weeds. Okay. So hilly areas, far-fetched areas where sea salt is not available or prone. But that was a scenario some time ago where the transport was not very proper. Nowadays we don't find that, but still there are prone areas for goiters. Okay, right. Proceed.
Okay, okay, sir. Yes, sir. History of presenting illness. The patient was apparently normal 4 years after noticed a small swelling in the anterior aspect of the neck with increase in the size for the past 5 months and reached the current size, which was progressive in nature associated with pain. No history of any other swelling, no history of fever. Next slide.
Okay. What do you mean by any other swelling?
Any other neck swelling, sir? Any lymph nodal swelling or any other swelling in the skull?
Okay. What is the importance of lymph?
Metastasis.
Okay. Presence of lymph nodes along with the goiter is suggestive of? Yes. What carcinoma is very common?
Follicular.
No. Follicular. In which cancer? In which thyroid cancer? Lymph?
Papillary.
First you should say papillary only.
Yes,
lymph nodal metastasis is very common in papillary CA. Okay.
Papillary.
The other side, follicular CA gives rise to hematogenous spreads. Through blood, follicular carcinoma spreads and gets deposited mostly in the bony prominences. Okay. Skull bone or long bones anywhere. This is one important thing which you should never commit mistake. All right. Lymph node means papillary CA. Hematogenous means follicular. Hematogenous.
Follicular carcinoma.
Lymphatic spread is papillary. Hematogenous is follicular. You should never forget.
Follicular.
Okay. Right.
Yes.
Okay,
Yes,
ma'am.
Next slide.
Yes.
No history suggestive of pressure symptoms like no history of difficulty in breathing, no history of difficulty in swallowing, no history of voice, no history of drooping of eyelids and absence of sweat on side of the face, no history of scope.
Your voice is not clear, ma'am. Goitre, there's a break in your voice. Yes. You proceed. If there is any problem, I will.
No, yes, it is. Shall I proceed, sir?
Yes. Proceed. So, I think you got the point correct. I have taken a previous class for you, I think. Okay. So, the history of present illness in thyroid disease is very extensive. There are so many, the plethora of complaints which are associated with thyroid disease. So, for clarity and convenience, I already asked you to group it into 3 domains, right? You are exactly doing that. Very nice. So, symptomatology pertaining to pressure, symptomatology pertaining to hypo or hyperfunction, then symptomatology pertaining to malignancy. Okay, right, very good. First, you also told pressure symptoms. Right, next.
Yes, sir.
Good.
No history suggestive of primary thyrotoxicosis like no history of excessive sweating, no history of weight, no history of heat intolerance, no history of diarrhea, no history of no history of muscle weakness, and no history of tremor.
You can avoid primary thyrotoxicosis, ma. The patient does not complain of hyperfunction of thyroid, like you can say. Yes, at this stage, the primary thyrotoxicosis and thyrotoxicosis, you cannot differentiate very closely like that. So you say the patient does not give complaints of hyperthyroid functions, like you can tell. Very good. Okay.
Okay.
Yes.
Okay, sir. No history suggests for secondary hyperthyrotoxicosis, like no history of palpitation.
I wanted you to avoid that.
Dyspnea, exertion. Yes, sir. No history of palpitation, no history of dyspnea, no history of edema of ankle, no history of chest pain.
Okay, ma'am.
Next slide. Yes, sir.
Right.
No history suggestive of hypothyroidism, like no history of weight gain in spite of poor appetite, no history of constipation, no history of cold intolerance, no history of easy fatigability.
Okay.
Next slide. No history suggestive of any malignancies, no history of sudden increase in size, no history of any pulsatile swelling over the scalp. No history of loss of appetite and loss of weight, no history of bone pain, no history of jaundice, no history of cough with hemoptysis, no history of headache, convulsions, and seizures.
Okay. Have you left out anything in malignancy? What is the main symptoms of malignancy in Goitre?
The nerve movement.
You told that?
No, sir. How can we tell in the history, sir?
The patient does not complain of
symptoms. I will told, sir.
Hoarseness of no history suggestive of. See, it is a dual thing. More than pressure symptoms, voice change is more frequently encountered in malignancy only. Okay. Pressure symptom can cause, but it has to be very big and very long to produce that. But malignancy, even at the very fast, it can involve the nerve, right? So, what is the type of malignancy which leads to early nerve involvement?
Anaplastic carcinoma, sir.
Very good. So, here you should essentially give the patient does not complain of hoarseness of voice or difficulty in articulation, you can tell. Okay? While hoarseness or difficulty in articulation, both are suggestive of nerve involvement. So kindly remember,
Okay, sir.
all students, this might be a very common question which can be asked. What are the symptoms of malignancy in a goiter? They ask you, you should tell nerve involvement for anaplastic. Okay.
Yes, sir.
Node disease in the case of papillary CA. So the patient does
Yes,
not give
sir.
history of hoarseness of voice or difficulty in articulation. The patient does not give any swelling on the lateral aspect of the neck. Patient does not give
Okay,
history
sir.
of any other swelling found pulsatile anywhere else in the body, or especially over the bony prominence. You tell this is all right. Okay, va?
Okay, sir. Okay, sir. Okay.
So once again, revise and get to know what are the symptomatology of malignancy. This is one standard question. Goitre இருக்கும்போது malignancy எப்படி present பண்ணலாம் அப்படின்னு கேட்டா அப்படி சொல்லணும். Okay. Nerve involvement in
Okay,
anaplastic, nodal disease in
sir.
PAPCA, and pulsatile hematogenic swellings over the scalp or bony prominence in
Follicular.
follicle. For each one, there is one important symptomatology. In addition to that, you have correctly said sudden increase, rapid increase in size, which has been recently noticed. Okay.
Yes, sir.
And
Yes, sir.
all other symptomatologies which are mentioned after that are very rare in a case of PAPCA, like loss of appetite, loss of weight, or very late symptoms. Okay, bone
Okay,
pain, of
sir.
course, may be present
Okay.
in follicular CA, but jaundice is very, very rare. Cough with hemoptysis is
Okay,
also
sir.
very rare. Those are all very rare. So,
Okay.
common symptoms you should tell first. Very good. Okay.
Okay, sir.
Proceed.
Past history. Yes, sir. Past history.
Yes.
No history of similar complaints in the past. No known case of diabetes,
Yeah.
hypertension, asthma, epilepsy, tuberculosis, jaundice, ischemic heart disease. No history of irradiation to the neck. No history of previous surgery. No history of any drug intake. No history of any allergy.
How will you actually ask the history of irradiation to the patient? You just imagine I am the patient. What will you ask me? How will you elicit the exact history?
In the early childhood, is there any treatment?
Like?
Treatment for lymphomas.
Right. So, therapeutic aspect
Hodgkin
or
lymphoma. Yes,
therapeutic or investigative, both things are possible. Repeated investigative radiation is also harmful,
yes,
right? You should have heard during the COVID era, they said
yes, sir.
what
Yes, sir.
CT scan is equal to so many number of X-rays. The radiation is
400
very heavy,
X-rays.
like that. Repeated CTs for some other disease is also a type of irradiation. Okay, that is investigative circumstance.
Yes,
The other one
yes,
is
sir.
therapeutic, as you rightly said. For lymphoma, they give mantle radiation.
For Hodgkin
Yes,
lymphoma.
and some other benign diseases also
Yes,
they give irradiation. Not in our part of the world. In India, it's very rare. In abroad,
Acne
yes, acne
vulgaris.
vulgaris, dermatological conditions. Okay, and they give irradiation, which is not common in our area.
Yes,
Those are all the circumstances. You should be able to ask the patient with this and obtain history. Okay, so what irradiation leads to what type of cancer?
Yes, irradiation.
After irradiation, what is the type of thyroid cancer? Huh? Follicular.
Papillary carcinoma, sir.
Yes, papillary carcinoma. That is one of the questions. Exactly. So, following irradiation, the type of thyroid cancer which can occur is papillary CA. What is the rough gap or window period after which malignancy can occur post radiation?
10 years, greater than 10 years.
Exactly. So it's a late onset. Okay. So post exposure, usually 10 years and after that only the patient will develop malignancy. The malignancy commonly following irradiation is PAPCA. These are all exam questions which you should be able to answer. Very good. Okay.
Yes, sir.
Go to the previous slide. Previous slide it go? Yes. Okay.
Past.
No history of drug intake, no history of allergy. Right. Next. Proceed.
Personal history. Not.
Hmm.
See, not diet. No adverse social habits. Take oil. No excessive intake of collagen. No history of alcohol sleep.
Your voice is not clear.
And now I'm audible.
Your connectivity is not good, I think.
Hello.
Kindly just. Yes. Proceed.
Yes.
Other students, are you able to hear her? Text me. Is Gayatри's voice clear for all of you? Voice disturbed, breaking. No, sir. Okay, Gayatri, your connectivity is somewhat not good, but you proceed. We'll see. Yes?
Age of 45. Family history, there is no
Okay.
history of similar complaints in the family.
What diseases of thyroid are running in family? Gayatri, tell me.
Sir, peroxidase deficiency, in the enzyme peroxidase deficiency.
Very good.
MENS syndrome is run in families, sir.
Yes.
MENS syndrome, sir.
What is the name one disease which is a component of MENS syndrome?
Sir,
MENS syndrome.
not audible, sir.
What is one common thyroid disease which is a component of MENS syndrome? Enna thyroid disease MENS syndrome?
Men 2 years.
No. What thyroid
Medullary
problem
carcinoma,
is?
sir. Medullary carcinoma,
yes.
sir.
It is medullary carcinoma. It can run in families. Okay. Peroxidase deficiency can run along. That is Pendred's disease. It can run in along families. In addition to that, other system malignancies also have to be inquired. Right? History of family history of ovarian cancer, bronchogenic cancer, other things also to be inquired. Okay, right. So menstrual history, what is the importance here? Anything contributory in this?
Sir, it is post-menopausal, so it is not much contributory, sir.
Okay, what changes can be noticed? Yeah.
Sir, oligomenorrhea in hyperthyroidism and menorrhagia in hypothyroidism, sir.
Okay, well done. Proceed. Next slide.
Summary. This is Komadi, 50-year-old post-menopausal woman with the complaints of swelling in front of the neck, with no history of history of hyperthyroidism, hypothyroidism, and malignancy symptoms. With the given complaints, I would like to examine the thyroid gland for the possible benign condition.
That's how we should summarize. So, just chosen the system. Okay, after the history. Yes. Okay.
Yes, sir. Yes, sir. General examination. After obtaining verbal consent from the patient examined in the well-lit room. The patient is conscious, oriented, comfortable, and cooperative. Moderately built and moderately nourished.
Yes.
The patient is febrile, no pallor, not icteric, no cyanosis, no clubbing, no pedal edema, no generalized lymphadenopathy, no tremor, and no evidence of toxic eye signs like lid retraction, lid lag, conjunctival congestion, corneal ulcers,
Very good. This presentation only I was emphasizing before. Okay. If the patient is in euthyroid state, this tremor and eye signs you can shortly finish off in general examination. Okay. If you get to examine a toxic patient, you should put it separately and elaborately describe about it. Any euthyroid patient, these things should exactly come like this. Where did you look for tremor?
Sir, tremor in the hand and tongue, sir. On protruding hand, there is a fine tremor, sir.
First, we will come to hand. Okay.
Yes, sir.
How do you examine tremors in your hand?
Sir, on outstretch the hand.
Yes. The patient can keep like this?
No, sir.
This like this. Okay.
Outstretch and extend the hand.
Outstretch hand, spread fingers, and ask the patient to close the eyes so that she's not conscious about the fingers. Okay. So how you should answer is, I like the patient to keep outstretched hand, spread the fingers and close the eyes, and I will see. Okay.
Okay, sir.
If obvious tremors are there, you will note it down.
Yes,
if no tremors also, you will note down. If there is doubtful whether there is tremor or not, what will you do?
Tongue tremor. We will see tongue tremor also.
No, in hand itself. You are doubtful. Irukra mari ingudhu illada mari irukra enna pannuva? Anybody can text. What you will do?
Paper is kept.
Yes.
Sir, some paper is kept over the fingers.
You should switch off the fan first. Okay.
Okay.
Fan switch off பண்ணிட்டு outstretch hand அப்படி வச்சு மேல ஒரு piece of paper should be kept like this. With the fan on, it will flutter. So you should avoid that. That's how. If you are doubtful about tremors, keep a piece of paper over the outstretched hand after switching off the fan and observe it. Okay. Right. Okay.
Yes,
that's it. Then the other place for tremor, ma?
Sir, tongue tremor, sir.
How will you elicit tongue tremor correctly?
Protruding the tongue outside.
Is it the correct method? Other students, can you ask the patient to protrude the tongue outside? Within the oral cavity, Kavya is answering. Yes, the tongue should not be outside the oral cavity. Otherwise, the patient will develop false tremors. Okay? You should ask the patient to open the mouth like that and elevate the tongue inside the oral cavity. Okay? Open the mouth.
Okay, sir.
Tongue should be elevated, not settled down. It will be elevated within the oral cavity without protrusion. Kindly remember, once the tongue is protruded out, you will see some tremors are there. Unintentional tremors will be there. So you should ask the patient to open, elevate the tongue within the oral cavity and look for tremors. Right? Okay. Next.
Yes, sir. Sir, what is tongue classification?
Is maybe some neural complaints, but the tremors are the tongue will as a whole move like that. Fasciculation are individual muscular movements. It is not a combined movement of the tongue itself. Fasciculation is individual muscle fibers. Segmental move over the fasciculations, we call it. Okay. Tremors are the what is a combined movement of all the muscles as a whole. Okay. Fasciculation, the individual muscles will fasciculate like that. So the tremors may be whole segment of tongue may not be moving. That is fasciculations, right? Okay.
Okay, sir.
Next.
Vitals. Blood pressure 130-80 millimeter of mercury. Respiratory rate is 17 breaths per minute. Pulse rate 7 per minute. circular in rhythm, normal in volume, no specific character, no radial delay, and radiofemoral delay, felt in all accessible peripheral
Okay.
vessels.
Local examination you should.
Inspection
Okay.
is a local examination. Inspection. The swelling is the swelling in the anterior aspect of the neck in the region of thyroid of size 6 cross 4 centimeter. Lower border is seen. Swelling moves with deglutition, not movement with protruding the tongue.
You are
Skin
not.
over the swelling is
No. The 6x, yes, you are not following properly. Shape you have given. What is the shape?
ovoid in shape.
போட்டிருக்கியா? என்ன எமர்ஜி தானே பண்ற நீ?
No, yes, sir.
சால்ட் நடுல.
No, sir, no.
I asked you to present a multinodular goiter with the euthyroid state, I believe. No?
Yes, sir. Multinodular goiter.
Usually, multinodular goiter is involving both lobes. So, usually it will be
Yes,
of
sir.
butterfly shape only. All swellings other than a salt nodule will usually be of a butterfly shape. The whole
Butterfly.
gland is enlarged with some nodules in it. Okay. So,
Yes,
again
sir.
and again, that 6x, 6s, I mean, okay. You should try to put it in the
Yes, sir.
proper way. A single swelling of butterfly shape is occupying the front of the neck or anterior aspect of the neck. Like that, you start. Single or multiple, size, shape, okay, and the yes surface,
Yes,
other things. 6s, okay, right. What is the shape you would like to attribute?
sir. Butterfly shape.
Usually multinodular goiterல butterfly shape தான் இருக்கும். And
Yes,
also
sir.
you should inspect the case and exactly give the what you are finding, but usually it is like that. Okay. Now refresh your presentation and tell again. Yes.
Sir.
A single swelling.
A single swelling which is butterfly in shape in
Yes.
the anterior aspect of the neck
Yes.
in the region of thyroid of size 6 cross 4
That's
centimeter.
very good. Yes.
Yes, sir. Skin.
Yes, sir.
Sir.
And
Surface.
obvious.
Surface is
Multinodular
smooth,
சொல்ற smooth
nodular surface. Nodular surface.
You are presenting a multinodular. No, you should say either nodular or
Yes.
uneven content. Anything is okay. Surface. What is the other is?
It's nodular surface. Skin over the swelling.
Tell me.
Skin over the swelling is normal, sir.
Okay. No scars, no sinuses. Now,
Yes, sir.
I want you to practice this 6s properly. I have repeatedly told
Yes, sir.
examination of swelling is very crucial for any system. So most of these pathologies will be like a swelling only. நீங்க திருப்பி practice பண்ணி you should have that method of not omitting out anything. All right. Okay. So single swelling of butterfly shape, size about 6 centimeter is found in the anterior aspect of the neck. The surface appears nodular or uneven, and this skin over the swelling is normal, no scars, no sign. Like that, you should at a good present it without omitting anything. Right, ma? Okay.
Yes, sir. Yes, sir. Lower border is seen.
Very good.
Swelling moves with deglutition. No movement with protrusion of the tongue. Skin over the swelling is normal. No scars, no sinus, and no dilated vein. No visible pulsation.
At the back. Okay, no problem. Okay.
Yes, sir. Trachea appears to be in the midline.
Okay.
No
Why
other
does the
swelling in the
thyroid
neck.
gland move upward on deglutition?
So the pretracheal fascia, which encloses the thyroid gland and attaches to the thyroid cartilage. So on deglutition, the larynx moves with deglutition. So the attached structures also moves with deglutition, sir. And the ligament of Berry, the postomedial condensation of pretracheal fascia condense to form Berry's ligament and attach to cricoid cartilage and some part of trachea. It
Very
also
good.
moves, so it is also reason
Nice.
for
Okay.
movement.
So that's a common question. Movement upward on deglutition region you should know. Very good. What are
Yes,
what is the pretracheal fascia?
sir.
What is it a component of?
Connective tissues and
Connective tissue.
sir, I don't know, sir.
It's a part of the fascia of the neck. Okay. Yes, Janavi is correctly saying.
Okay, sir.
It is deep cervical fascia. Okay. And before moving on, I would like I am very cheerful.
Investing layer of deep.
I am cheerful in telling this to all my students. Okay, va? Abdomen neck ko contrast undu. Okay. In neck,
Yes,
the superficial fascia is negligible, whereas the deep fascia is very prominent with 4 lamina. Right? Deep fascia surrounding the neck is of 4 lamina are there. On the outermost is called the investing layer. Okay. So the other component which is going there and encasing the thyroid is the pretracheal. That is the second component or second lamina. Right?
Yes, sir.
The third one which goes behind and covers the muscle is called prevertebral component. And the fourth component which goes and encloses the vessels is called, what is the fourth component of the deep fascia? Anybody can text? Yes. Carotid sheath. Okay, wow. This question, some examiners are very much interested in asking. What are the 4 lamina of the deep fascia of the neck? If you ask, you should immediately tell investing layer, pretracheal fascia, prevertebral fascia, carotid sheath. There are 4 lamina of the deep fascia. This is regarding the neck. Whereas in abdomen, the superficial fascia is very prominent. The deep fascia is very negligible. Okay. Rendume reverse arukum. Neck superficial சின்னதா இருக்கும். Deep fascia very, very prominent. Whereas in abdomen, superficial fascia is very prominent. Deep fascia is very, very negligible. So the superficial fascia has got 2 lamina, namely a fatty layer and a membranous layer. Campers and scarpus, we call it. Okay. I am very fond of this difference, contrast. I always enjoy that because as a surgeon, you get to operate, you will come across all these things. So that anatomy gets stuck into your head. Never forget this, the contrast of fascia between abdomen and neck. Okay, right.
Yes.
So your pretracheal fascia is a part of the deep fascia of
deep cervical fascia. Yes.
Yes, right. Next one. How do you make out that trachea is in midline?
Sir, inspectory findings, sir.
How by inspection?
Trial signs, sir.
Yes. What is trial signs?
In trial signs, prominence of that sternocleidomastoid muscle on the side of deviation of the swelling.
So the trachea is deviated, it will make that side sternocleidomastoid sternal head of sternocleidomastoid will be lifted. It will be prominent. So that implies there is a pathology on the opposite side. There is a huge swelling on the left side. It will push the trachea to the right side. Okay. So on inspection, both sternocleidomastoid sternal heads are equally seen, means you assume that it is in the midline. In addition to that, in thin individuals, sometimes you can ask them to swallow and the rings of the trachea may be visible in very thin individuals. That's also a possibility. But on inspection, how do they make out trachea in midline means you should say trial signs. I look for trial signs. You should be able to describe the trial sign. Okay.
Yes, sir. Yes, sir.
Other students, is it all right? If you have any doubt, you can ask me. These are all exam-oriented questions. Actually, what the examiners will ask only, I am telling you. Okay. Right. Next. No other swellings means lateral neck swellings, right?
Yes, sir.
Okay. Right.
Palpation.
Okay.
No warmth, no tender. The swelling
Yes.
of size. Butterfly shaped swelling of size 6 cross 4 centimeter on the
You can
anterior
simply
aspect of
tell,
the neck.
no, the inspectory findings regarding the size, shape, extent is confirmed on palpation. You can tell if it is the same.
Okay. Okay.
If there is any doubt, you can elaborate it. Otherwise, you will not tell everything again. Okay. There is no
Yes, sir.
warmth, no tenderness. The inspectory findings regarding the size, shape, extent, surface confirmed on palpation. You can finish.
Palpation.
Okay.
Yes, sir.
Then.
Extension.
Yes.
Lower border extending 2 centimeter away from the suprasternal
Very
notch.
good.
Upper border extending 1 centimeter from the
Good.
hyoid bone. Right side lie close to the anterior border of
Nice.
sternocleidomastoid. Left side 2 centimeter away from the anterior border of
Okay. That
sternocleidomastoid.
is the extent. Next.
The surface is nodular, firm in consistency, well-defined margin. Mobility moves in horizontal and vertical direction. Carotid pulsation is felt on both sides. Berry sign is negative. Trachea in the midline. No other swelling is present. Coach's test is negative. Pemberton sign is negative.
Surface is nodular, right? You can be a bit more
It's a
specific. How
nodular
many
surface.
nodules are there? See, this is how a multinodular goiter should be presented. I tell you, on palpation, no warmth, no tenderness. Inspectory findings confirmed. On palpation, there are number of nodules. You can tell roughly. Okay. On an examination, you can pass your finger and see over 4 nodules in the show. There are the surface appears nodular. On palpation, there are around 5 to 6 nodules occupying both lobes of the gland. Okay, wow. So multinodular means more than one nodule is there. It is occupying both lobes and solula. That will be a better presentation.
Yes,
okay, right.
Yes, sir.
There are about 5 nodules or 6 nodules occupying both lobes. The biggest of which is so many size, you can tell like that. Okay. And second line, I don't agree. What is that movement with the horizontal?
Sir, is there any fixity to deep
No,
structure?
normally the thyroid gland is mobile. You catch up a thyroid swelling and move it, it will nicely move. Is that?
Yes, sir.
Thyroid has got a intrinsic mobility very free, or it is restricted. Other students, what is your opinion? See, normal thyroid irukku. Okay, there is a swelling coming from the thyroid gland. That swelling is easily mobile. Karthik is saying restricted. I agree with him. Normally, the thyroid is encased by a sheath, which is called pretracheal fascia. So, by default, the thyroid has got a restricted mobility only. Very, very minimal mobility only. So, side-to-side mobility, it is not proper because it is not a very mobile organ. So, how you should put it? There are 2 mobilities for the thyroid gland. One is movement upward on deglutition, that is no controversy, right? The upward movement of deglutition is one movement which is happening in the thyroid. The other one is intrinsic mobility. You catch it up and try to move it. By default, it has got a very restricted mobility only. So, Even that little mobility, if it is totally absent, you should think of
Malignancy.
anaplastic CA. Okay?
Yes, anaplastic.
Or
Yes,
sometimes
sir.
inflammatory thyroid conditions where the inflamed
Chronic.
thing will be stuck. Yes. Hashimoto's
Yes.
thyroiditis or woody thyroiditis, like that. So how
Yes,
we
sir.
should put is mobility, the intrinsic mobility is not restricted. You should
Yes.
put. Okay,
Yes,
normal restriction is there, but total absence is not there, means there is no malignancy, you should make out. But
yes,
if you are presenting a case of anaplastic carcinoma, you should tell the intrinsic mobility is totally restricted. Okay,
yes, sir.
so
Yes, sir.
by default, the thyroid has got a small restricted mobility. Even that restriction, a small mobility is totally lost. You should think about anaplastic CA or a inflammatory thyroiditis. So
Yes.
swelling, thyroid swelling நல்லா move ஆகுது side by side vertical சொல்லக்கூடாது. You understand? The
Yes.
intrinsic
Okay,
mobility
sir.
or independent mobility is not restricted. It's restricted. Then it is a benign condition. We will assume.
Yes,
Okay,
sir.
fine. So next time when you present, when
Yes,
our
sir.
unit students present, I will expect this. There are two mobilities of the thyroid gland. One is movement on upward on deglutition. The other one is intrinsic mobility.
Intrinsic
It is
mobility.
present there in a benign condition. Not freely mobile, horizontal, vertical mobile. Okay, right. Next one. So Berry sign. What? When is Berry sign positive, ma?
Sir, when the malignant thyroid engulfs the carotid sheath completely.
Yes. Okay. So
the pulsation is not felt.
Yes, it could either be due to the gland itself enlarging and encasing the carotid artery.
Carotid
Number
sheath.
one thing,
Yes, sir.
or a secondary nodes. Okay, that a primary papillary CA is there. Extensive nodal disease is there. The node itself can encase and cause absence of carotid pulses. Both are possible. Okay, va?
Yes, sir. Yes,
Absence of carotid pulse can be due to the primary itself coming and encasing, or secondary nodes again causing it. It could happen in two scenarios. Okay, right.
Yes, sir.
Right. Hodgkin's test. What is it?
To rule out the tracheal narrowing, sir, the
What do you
patient
do?
asked to slightly extend the neck, sir,
Okay.
and take a deep breath on pressing the mild pressing over the lateral lobe of thyroid. There may be stridor is present if the trachea is compressed.
Okay. You keep your hand like this on one side and push it on the opposite side. The patient will immediately have stridor and difficulty. Okay. So
Yes, sir.
yes. Then what is Cabot trachea?
In multinodular goiter, compression of trachea, lateral compression of trachea.
So the tracheal lumen, which is supposed to be a circle, will become like a elliptical mariadum. So lateral compression, two lobes are there, they are pressing the trachea.
Yes, sir.
The trachea was like this, they press and make it like this. Okay, that is called scabbard.
Yes,
Scabbard name? What do you mean by scabbard?
I don't know, sir.
கத்தி வைக்கிறோம்ல அந்த உரை. That's a case sword, no? The kings used to push the sword. கத்தியோட உரை இருக்குல்ல, அது எப்படி இருக்கும்? இப்படிதானே இருக்கும். அது உள்ள கத்தி போகுது இல்லையா? அந்த மாதிரி ஆயிடும் ட்ரக்கியா. உருண்டையா இல்லாம சப்பை ஆயிடும். So you go and Google and see what is scabbard. Scabbard is the cover inside which a long sword is kept by kings of those periods. Okay, right. So lateral compression. So the scabbard trachea can occur in many conditions, not only malignancy. Yeah, diffuse enlargement of both lobes. Yes, non-toxic multinodular it can happen. diffuse colloid goitre பெருசா இருந்ததுன்னா ரெண்டு சைடு வந்து பிரஸ் பண்ணும்போது கூட வரலாம். So it implies that both lobes are enlarged and pressing. Okay, it can happen in malignancy, it can happen in multinodular goiter with toxicity, multinodular goiter without toxicity, or a diffuse goiter with toxicity without many conditions. Only condition is unilateral enlargement will not cause scabbard again. Both lobes will enlarge and press. That's the thing. Okay, right. Next.
Yes, sir.
So Pemberton is suggestive of what problem?
Retrosternal extension, sir.
Yes. How do you elicit Pemberton sign?
The patient has to raise both the arm over the head until they
Yes.
touches the ear and
Okay.
maintain for a while, and there will be a congestion of face and respiratory distress, dilation of anterior neck veins,
Yes.
suggestive of it.
So venous return into the heart is obstructed because of retrosternal goiter. The veins in the mediastinum, namely the brachiocephalic vein, is compressed. So venous return is delayed and the congestion of face occurs. Okay. Then next slide.
Yes, sir. Percussion, no retrosternal dullness. Auscultation, no brood heard. Examination of other lymph nodes, no palpable lymph nodes in the neck region. Other system examination, respiratory system, normal vesicular breath sounds. Abdomen, no tender, no organomegaly, normal bowel and bladder, normal bowel sounds are heard. Cardiovascular system, S1, S2 heard and no murmur. CNS, no focal neurological deficit. Oral cavity, no macroclasia, no tongue tremor, no tongue fasciculation, and no lingual thyroid.
What is the importance of
Spine and cranium are normal.
auscultation goiter?
To see brood
Yes.
due to the vascularity,
Okay.
increased
What
vascularity
condition
of the
you will have?
glands.
You will hear a bruit.
It's a primary
Very good.
thyrotoxicosis.
So the Graves' disease or primary thyrotoxicosis is a condition where a bruit will be heard. Okay. Because of what, ma? Why is it so?
Yes,
Why is it bruit?
because of increased vascularity, sir. Sir, because of increased
Increased
vascularity.
vascularity, hyperdynamic circulation, you can put it another way. Okay. Where will you look for? Where is the bruit
Yes, sir.
prominently heard?
Mostly in the upper pole of the
So
lateral
superior pole,
lobes.
we should tell. The bruit is well heard
Okay,
over
sir,
the superior pole. Why?
Superior pole. Sir, the superior thyroid artery,
Yes.
it's undivided.
Okay.
Undividedly enter the artery,
Okay.
sir. After that only it get divided, sir. Then superior thyroid
Very
artery is
good.
most anteriorly placed. Then in right
Yes.
and left superior thyroid artery anastomose the superior border of the
Very good.
isthmus. So contributory turbulence,
Bruit.
it
Okay.
increases
So three reasons you have nicely
increased
told.
it
One
causes
is that superior, it is heard well in the superior pole because superior thyroid artery is more anteriorly placed. It is a relatively simple vessel and it has got established anastomosis with the fellow of the opposite side over the superior border of the isthmus, resulting in contributory turbulence. So, all students kindly remember three things. You should never fail to answer this question. Okay? கேட்டா உடனே டக்குனு மூணு ரீசனும் கட்டாயம் சொல்லணும். Okay. Right. The reverse is the happening in inferior thyroid artery. You should also remember that. Inferior thyroid artery is not superficial. It branches even before entering the capsule and the branches. Okay.
Yes,
and there is no anastomosis the opposite side at all in the inferior thyroid artery. Yes.
Yes.
Next one, yeah.
Summary. On examination, non-tender nodular swelling of size 6 cross 4 cm with well-defined margin, firm in consistency, and no signs of retrosternal extension and no clinically palpable lymph nodes in the region of thyroid. Provisional diagnosis: it is probably a case of non-toxic, non-malignant multinodular goiter without complication, and proceed for further investigation, sir.
One examination on a history summary. Is the age of the patient important?
Yes, sir. 50 years.
Summary should, this is not the way you summarize. Okay? How I summarize, you just see. Okay? What is the age of the patient?
Yes. 50 years.
Okay.
50.
A middle-aged lady presenting with complaints of reasonably short duration swelling occurring in the region of the thyroid, not associated with any pressure symptoms or hypo or hyperthyroid function, and with no signs of malignancy. I would like to make a which on examination. Now we should come. Okay, va? Modalla history la irudala nama eduthuknom.
Okay.
Middle-aged lady presenting with recent onset of painless swelling in the region of the thyroid, not complaining of any pressure symptoms or hyperthyroid functions symptoms or malignancy, which on examination reveals a butterfly shaped swelling of size with uneven surface, multiple nodules seen with no regional lymph nodes and all. I would like to make a diagram. That's how we should summarize. Summary la history la konjam eduthukonom. Why it is important, I tell you, இதே ஒரு பிரஸ்ட் எடுத்துட்டோம்னு வச்சுக்கோ, 65-year lady வந்துச்சு, ஒரு 30 years lady அல்லது 28 years girl வந்தாங்கன்னா, the age is very, very, very important there. Here also the age is important. As the patient becomes elderly, the chances of malignancy are more. Okay, so summary la எப்போதுமே history ஒரு first part should be history compilation, then your examination compilation, and then we give a provisional diagnosis. Okay, right. So it's a case of non-malignant, non-toxic, multinodular
goiter.
Okay, right. What will you do for the patient?
Sir, investigation, yes. Sir. Routine investigation. Okay. Complete blood count, hemoglobin,
we'll
total count, differential count.
That. Come to specific investigation.
Yes, a specific investigation, thyroid function test, X-ray neck, USG neck, fine needle aspiration cytology, and indirect laryngoscopy.
What are the components of thyroid function test?
TSH, T3 and T4.
What do you expect in this case?
Sir, it is euthyroid, so it is in the normal.
All three things are likely to be in the normal state only. Okay.
Normal state, yes.
What will you? How is X-ray contributory?
X-ray to see the position of trachea, sir.
Okay.
If there is any retrosternal extension, cervical spondylosis, sir, for surgery purpose.
Very good. Okay.
Is there any calcification is present?
This is very rarely seen. So X-ray is not very, very contributory for confirming the diagnosis. Okay. Right.
Yes,
otherwise, the other thing, USG is very important. What are the things you would like to see in USG?
Composition of the swelling, sir, whether it is solid or cystic.
You go in an orderly fashion. First, I would like to confirm thyromegaly. Right?
Yes, sir.
Neck la ultrasound பண்ண என்ன சொல்லுவாங்க? அது thyroid தானன்னு first சொல்லணும்.
Yes, sir.
If it is in this position, it can arise from something else also. They can make out. So,
yes, sir.
Ultrasonogram of the neck in a goiter. First, I will confirm that it is thyromegaly. Number one. Okay.
Yes, sir.
Next one is you want to confirm that it is a multinodular goiter. How will you confirm?
Number of nodules.
Uh,
Number of nodules.
and
Any clinically non-palpable nodules can be.
very good. So number of nodules, placement of nodules, and any clinically not palpable nodules can be assessed or evaluated with using a second component. Third one, nature of nodules, as you have said. What is it?
Yes, sir. Solid or cystic.
Why is it important?
Nodules. Sir, solid, it more towards the malignant side, sir.
Okay.
If it is cystic,
Yes.
it is
You can
benign,
come to
sir.
a conclusion. Anything else is important
Yes.
to make out?
Sir, margins are regular margins.
That is to differentiate.
Sir?
But solid or cystic, what is the other
Yes, sir.
use? No, Janavi is correctly
Echogenicity, sir.
posting.
USG guided.
USG guided FNSC, you should take it from the solid component.
Solid
Right?
nodule.
Cystic component, the FNSC, the yield or usefulness is not good. You should obtain a FNSC from the solid component. That's why you should see solid or cystic, one thing. As your other told, hypoechoic areas are more suggestive of malignancy.
Malignancy,
Okay?
sir.
Of course, there are other features of
Yes.
nodule which can decide whether it is a benign or the malignancy, but that is applicable mostly for a solitary nodule only. Okay.
Okay, sir.
So, ஒரு nodule malignant benign கண்டுபிடிக்கிறதுக்கான is shape, size, okay, and echogenic pattern, calcifications. All these things are applicable mostly for a solitary nodule. So, multinodular mostly of no use, not very much applicable.
Okay, sir.
So, USG எப்படின்னா first confirm thyromegaly, evaluate the number of nodules, placement of nodules, any clinically not palpable nodules, we can make it out. Then
Yes, sir.
see whether they are solid or cystic. What is the fourth use of USG? Nodes you can see. Okay. Sometimes clinically nodes will not be palpable, but ultrasonogram will be able to pick up clinically non-palpable nodes. So 4 uses of ultrasonogram in evaluation of a goiter, you should remember. Right, Goitre? Right.
Yes, sir.
Okay, go ahead.
Fine needle aspiration cytology.
Yes. In what conditions FNAC is helpful? In what condition it is not helpful? Give me a few conditions.
It is helpful in medullary carcinoma, papillary carcinoma.
Anaplastic carcinoma.
It is not helpful to anaplastic carcinoma.
And other.
It is not used to distinguish the follicular adenoma and follicular carcinoma.
Yes. Why?
There we can't see the capsular and vascular invasion.
If capsular invasion or angio invasion is present, it is follicular carcinoma. If it is not present, yes. It is adenoma. But the FNSC cannot show the vascular invasion or angio invasion. It is only cytology. ஒரு செல்லை மட்டும் எடுத்து பார்க்கலாம், அதுதான் cytology. Okay, it is not a tissue reading, so it is not helpful. Okay, and other conditions can be diagnosed other than malignancy also, you should know. Like in
Hashimoto's thyroiditis.
Yes, inflammatory conditions also. Hashimoto's thyroiditis.
Papillary adenoma, sir.
Adenoma also. Benign neoplasms. And sometimes they say even a colloid nodule, expert sonologist can even diagnose a colloid nodule. Okay.
Yes.
Right.
Yes.
Next one. Yeah.
Indirect laryngoscopy, sir.
Okay. Purpose?
It's a medico-legal purpose. In 3% of individual, there is a unilateral silent vocal cord paralysis is present.
That is very important. Silent vocal cord paralysis. So you go ahead and operate, the patient will go in for stridor without your mistake, because the other side is already paralyzed due to silent vocal cord paralysis. And document it for legal purposes.
Yes.
Okay, right. Will you go for any radioactive iodine abstract study in this case?
Sir, in you.
You are correct. Come.
You
will do or not in this case? Radioiodine uptake study or scan, you will do or not?
No need.
In this case?
No,
you
sir.
will not do for this case. Yes, no, sir is the correct answer. Why? Where will you do?
In case of toxic nodular goiter, sir.
Very good. For evaluation of a toxic goiter and doubtful toxicity, you can do. One doubtful toxicity இருக்கணும். இல்லைனா to evaluate an obviously toxic goiter only, you use a radionuclide scan. I will not use it for a euthyroid patient or hypothyroid patient. You should be very specific. யோசிக்க கூடாது, இது பண்ணவே மாட்டேன் ஏன்னா the patient is obviously in a euthyroid state, there is no indication. Okay, I will do it only in a doubtful toxicity case to confirm it, or in an established toxic case to evaluate the nodule pattern, which part of the nodule is toxic adenoma இருக்குன்றத பார்க்கிறதுக்கு கூட sometimes we use. So there is no role for radionuclide study in a case of euthyroid goiter. Okay, right. Yes. What is the treatment then?
Treatment is total thyroidectomy, sir.
Okay. What do you mean by total thyroidectomy?
Removal of both the lobes and along with the isthmus.
Yes, that's it. But the endocrinologist put it in a in another fashion. Okay. So they say total thyroidectomy is the removal of all visible thyroid tissue. They say. அவன் என்ன சொல்றான், லோப் இஸ்துமஸ் சொல்றான். அவன் என்ன சொல்றான், அது இல்லாம ஒரு பிரமிடல் லோப் இருந்தது, எக்டோபிக் இருந்தா அதிகம் எடுத்தோம்னு அப்படின்றாங்க. ஸோ டோட்டல் தைராய்டெக்டமி மீன்ஸ் ரிமூவல் ஆஃப் ஆல் விசிபிள் தைராய்ட் டிஷ்யூ. ஆமா, சில எக்ஸாமினர்ஸ் will want you to tell both lobes with isthmus also, but get to know about both aspects. Okay, total thyroidectomy is the removal of all visible thyroid tissue, including both lobes and isthmus, you can tell. Okay, how will you do the surgery, ma?
Sir, we get the patient anesthetically fit, sir. First.
Good, ma.
Under endotracheal general anesthesia, the patient in the rose position, supine.
Very good.
With extended neck, and the sandbag is placed between the scapula.
Very good.
Under strict aseptic condition, low collar incision is made transversely.
Very good.
2 centimeter above the suprasternal notch.
Okay.
And extending up to the anterior border of sternocleidomastoid.
Nice.
And raise the skin and subplatysma. In the deep fascia, vertical incision is made, sir. And the strap muscles are divided and retracted laterally.
Okay.
Middle thyroid vein is identified and ligated first.
So
superior pedicle.
So undergraduate level,
superior pedicle
level you divide into 5 steps. Okay, va? So strap muscles retract பண்ணதுக்கு அப்புறம் there are 5 steps. Middle thyroid vein, superior pedicle, inferior pedicle.
Superior pedicle, inferior pedicle, recurrent laryngeal, safeguard the recurrent laryngeal nerve.
No, parathyroid
ligament is cut.
Okay, va?
Parathyroid.
So
okay.
Each of these things has to be done then you divide that and remove that. Okay, right. So post-operative.
Yes, sir.
So I think it's 10:30. We'll wind up soon. Before that, mm, post-operatively,
Yes,
how
sir.
will you follow a total thyroidectomy? You tell me. The other aspects, no, like complications of surgery, there are many more, a lot of discussions. Subsequent classes, what we have not discussed in detail, I will discuss. Before we finish up, what is the post-operative follow-up for total thyroidectomy? You tell me.
Sir, I am not sure, sir.
நம்ம total thyroid எடுத்துறோமா ஃபுல்லா என்ன பண்ணணும்? Post-operative what will do? What is the difference between a hemithyroidectomy and total thyroidectomy?
Sir, in hemithyroidectomy,
Kaushalya is
a part,
answering.
one lobe and the isthmus is removed. Sir.
So the patient does not
One
read.
lobe and isthmus is removed.
Yes.
Hypothyroidism. Sir.
What will you do for that?
In that we give supplement dose of thyroxine, sir.
Kaushalya is text that replacement of thyroxine. Okay, you should tell.
Okay.
After total thyroidectomy, post-operatively, I will start the patient on replacement dose of L-thyroxine. You should tell. There are two types of L-thyroxine administration. One is replacement dose. The other one is suppressive dose. Okay. In a malignancy which far off metastasis, they will keep on secreting. So to suppress that, you give 3 times the L-thyroxine. Replacement dose is 3 times the. Suppression dose is more. It is 3 times the replacement dose. For benign conditions, you will give. I will start the patient on replacement dose of L-thyroxine post-operatively. You should tell. Okay. So we will wind up with this. I think we have discussed about the history taking examination. I have discussed a few things. Okay. Subsequent procession. What doubt, ma? Janavi. You can unmute and ask. No problem. Janavi.
Yes, sir.
What's your doubt?
The replacement dose, sir, you cannot give it orally, no, sir, for some time.
It has to be given orally only. All L-thyroxine is oral only.
After how many hours can it be given, sir, post-surgery?
Before surgery, the circulating hormones, okay, they are likely to stay in the system and support the patient for about 1 week. Okay, va? Preformed hormones which are already there will sustain for a week's time. So it is a common practice to start on L-thyroxine in the second week. Thyroid பண்ணிட்டு ஒரு வாரம் வரைக்கும் வச்சுக்கலாம், ஒன்றும் பிரச்சனை கிடையாது. Okay?
Okay, sir.
Any doubt? L-thyroxine is given orally only.
Yeah, okay, sir.
Thyroxine is oral route. It is started. You start to give L-thyroxine in the second week. 1 week, the patient can sustain with the preformed hormone which is already circulating in the body.
Okay, sir.
Does that make your question? Have I cleared your question? Yes.
Yeah.
Very good. Shall we wind up? Okay. If you have any further doubt, you can always come and get it clarified in subsequent classes. Okay. Where is our presenter? She's not under answering. Goitre,
Yes.
you slept?
Sir, am I audible, sir?
Yes,
No,
yes.
sir.
Yes. Nicely presented.
Thank you, sir.
I'm keeping you all awake. Go and take rest. Get prepared for your exam. Yes, we will have subsequent classes. இதுல எது நான் மிஸ் அவுட் பண்ணணும் அதெல்லாம் subsequent classes we will try to clarify it. Okay, like complications and toxicity management, and complications of surgery, nerve injuries. There are very many things which we will discuss. Subsequent classes we will discuss. Thank you for being with me. Good night.
Thank you, sir.
Thank you,
Good night,
sir.
Good
sir.
night. Good night.
Thank you.